Hi, my name is Samantha Maines, and I will be going through a case study with you. This was on a patient that had cellulitis due to Pasteurella multocida with bacteremia. So we will be talking about some laboratory tests, and hopefully by the end of this presentation, we will be able to complete these three objectives. So upon completion of this case study, the student or observer will be able to complete the following objectives at the taxonomic level listed with a minimum of 80% accuracy. For level 1, we want to list the general characteristics and major features of Pasteurella species. For level 2, we want to describe the identification procedure for this organism, including biochemical tests, workups performed in the laboratory, and confirmatory procedures. And for level 3, we want to correlate bacteria to the clinical infection and treatment while including sequelae of infection if not appropriately treated. Fortunately, this patient was appropriately treated, but we shall get into that shortly. So the background, we have a 63-year-old female with rheumatoid arthritis, deep vein thrombosis, which they were not on anticoagulant therapy for this, and I note this specifically because we will be going through the hematology results, but we'll get into that later in this presentation. This patient had a bilateral total knee arthroplasty or replacement and a left prepatellar bursa infection, chronic pain syndrome, and chronic opioid use. This patient presented to Pennsylvania Hospital on November 3rd, 2019, with 2 days of worsening right lower extremity pain, swelling, arrhythmia associated with subjective fevers, and nausea, symptoms concerning for right leg extremity cellulitis, septic arthritis of the right knee. So, this patient was previously seen in August with right lower extremity swelling and superficial wounds that were draining clear liquid that was thought to be mild cellulitis and treated with C-Flex, which is a cephalosporin commonly used for skin infections. This patient was seen again by the primary care provider in September, so just a month later, and their condition was not getting any better, and they were treated with another antibiotic, Augmentin, which was a combination of amoxicillin and clavulate, and the patient was improving a little bit. However, now in August at Pennsylvania Hospital, November at Pennsylvania Hospital, there were symptoms that were concerning for cellulitis and septic arthritis of the right knee, and they were taken to the ER, like I said, November 3rd. So the laboratory tests that we will be getting into are the microbiology side of blood cultures, body fluid cultures, and tissue cultures, as well as the hematology side that we're going to go over their CBC and differential. Other laboratory tests that were performed were the BMP, CRP, fluid counts, and the heme profile. However, we will not be diving too far into those. So for the microbiology lab, blood culture bottles were taken and they were put in the back tech. If you do not know what a back tech is, please let me know and I'll be able to explain it. So they were taken on the day of admittance at Pennsylvania Hospital, and one of 4 bottles, the anaerobic bottle, came up positive 1 day later, so about 24 hours later. The gram stain initially showed gram-positive cocci in pairs. However, there was some issues with staining. Not all organisms stain perfectly, so some slides were coming up negative, and it is the microbiology technologist's job to really have a sense of what is going on that slide, but this is why we do other tests to distinguish what organism is growing. So after the organism grows up, we look at the plates about 16 hours later. So there was growth on the blood agar plate, the chocolate plate, and the anaerobic blood agar plate that showed tan colonies, whereas McConkey and CNA showed no growth. The oxidase test came up positive, and after gram staining the isolates from the blood agar plate, the microbiologist was able to confirm that the slide was showing gram-negative coccobacilli. And because of that gram stain, a rapid NH was set up. So this is the gram stain of gram-negative coccobacilli. And this is a rapid NH test. So Thermo Fisher has a rapid test that has the capability of looking at a variety of enzymes that this particular genus and species would be able to incorporate. So this technology is able to identify over 30 taxa, including Neisseria, Moraxella, Haemophilus, and related microorganisms in just 4 hours. And we will go over this is how you score it, and it's just the report form, and there's different biochemicals that are tested here, and we want to see if a particular organism has the enzymes able to break down a variety of different biochemicals. So I won't get into the nitty-gritty of this. If you have any questions, please list them in the comments below. But I do want to note that the bug that is in question was oxidase positive, catalase positive, urease variable, indole variable. Nitrate was able to be reduced to nitrite. It was VP negative and methyl red negative. So at this point, one of the microbiologists was able to read this test, and you're going to score it below to get a 4-digit number. And through Thermo Fisher and Remel, you put that code into the computer, and it'll tell you with a certain percentage of confidence that that bug is whatever it identifies out to be. So this bug was able to be distinguished as Pasteurella multocida, and there was a question as to whether or not it would be Haemophilus influenza, because these bugs are extremely similar to each other. However, Haemophilus influenza stains negatively, whereas we saw that Pasteurella had the bipolar staining, and it was very difficult for the technologist to really get a solid gram stain. Other distinguishing factors is Pasteurella is also oxidase positive and catalase positive, Haemophilus is oxidase variable and catalase variable, as you see in the table here, and it may or may not be able to reduce nitrates beyond the nitrite form. And another distinguishing factor is that Haemophilus influenza requires both X and V factors for growth, and Pasteurella does not require these factors, which is one of the main determining factors as to whether or not it would be Haemophilus influenza or Pasteurella. So the body fluid, so this was all in one of 4 bottles in the blood cultures. In the body fluid of this patient, it grew the same Pasteurella species and it had the same sensitivities. So because we identified this organism through the rapid NH system, we did not use other technologies. We were able to set up a Kirby Bower plate, and according to the requirements that we need for the antibiotics that we tested levo, trimethoprim, and cefotriaxone, and they were all sensitive, which is very, very good for the patient. And the tissue cultures that were submitted from surgery from this patient from the right knee resulted in the same growth and the same sensitivities. So that means that this patient only had one organism that caused the infection, and it was sensitive to these 3 antibiotics. So this is just some fun facts about Pasteurella. Pasteurella species are normally respiratory and GI flora of animals, and humans acquire the bacteria from animal bites, cats and dogs, or by the inhalation of dried animal feces. Pasteurella can cause cellulitis, but it can progress into osteomyelitis, meningitis, joint infections, and pneumonia, which we saw it progressed to sepsis and joint infections. And Pasteurella multocida is the most common cause of human infections, that specific species. It grows well on non-selective augars, such as blood and chocolate plates, but not McConkey. It is oxidase, catalase, indole, and nitrate positive, a non-motile pleomorphic gram-negative coccobacilli. They may show bipolar staining, and it is very susceptible to penicillin. So 1 of 4 blood cultures popped up positive, and sometimes we think that might be a contamination. However, this patient was sick enough to get surgery a few days later, and due to the abnormal staining, it was most likely not a contaminant. And if the doctor only noticed that it was 1 of 4 bottles for the blood cultures on November 4th, and he thought it was a contaminant, he must have also looked at the hematology results and saw that they were a little bit out of range, which might have indicated that there was some sort of infection. So we are now going to switch gears into hematology, and this is the hematology results from this patient. And the 3 things that stand out are the red blood cells were very low, the hemoglobin was very low, and the hematocrit was very low. And now we are getting into the manual differential. So the white blood cells are distinguished by what type of cells they are, and the 3 cells that we really want to hone in on are their segmented neutrophils, which this is the relative percentage and the absolute count of the segmented neutrophils for this patient, and it was very, very high. And the lymphocytes and the monocytes are extremely, extremely low. And the red blood cell morphology had hypochromia, which is also indicative in the previous results here. So these results display that this patient has a large circulating population of segmented neutrophils, which is indicative of a bacterial infection and sepsis. The lymphocytic population is decreased, which is expected due to the patient's diagnosis of sepsis. So the segmented neutrophil population drastically increases, so your body is able to fight off a bacterial infection. The lymphocytic population is usually more necessary to fight off viral infections and not bacterial infections. So these hematology results are consistent with the bacteriology of this patient. So this patient was initially started on broad-spectrum antibiotics. Blood cultures were taken on a mission, and they were positive for Pasteurella multocida. They were pan-sensitive, beta-lactamase negative. So, because of those results, the patient was narrowed down to the IV ampicillin because Pasteurella is extremely sensitive to penicillin and ampicillin. And antibiotic therapy was anticipated to last 4 to 6 weeks in total since the first negative blood culture via the PICC line, and this therapy was completed and the patient was discharged. So now we are going into the 2 questions that I have for you to complete the objectives. And if you could answer these questions in the comments below, that would be wonderful. So question number 1, what bacteria would gram stain display from these tissue cultures? Would you expect to see white blood cells? So what would the gram stain show? And would you expect to see white blood cells in the gram stain with the hematology results that we know of for this patient? And for question number 2, what would the workflow look like for the microbiology lab working up this specimen? For example, what agar plates would have displayed growth, and what biochemical tests would be utilized to correctly identify this organism? And here are the references that I used, and if you have any other questions, please feel free to reach out to me, and thank you for watching.